Hi everyone, and thank you to be here for our last conferences. I know that the day was a little bit long, but no worries, we are coming to the end. And to be honest, I am so happy to introduce you our last speaker as an international recognized expert in sex and gender medicine. She is the Division Director of the first program in sex and gender emergency medicine in Brown University in USA, and the co-founder of the Sex and Gender Women's Health Collaborative. She will share with you all the difficulties of being a woman in the medical field and explain us how male medicine may endanger women's health and what we can do to change it. So I am obviously talking about Alyson McGregor. Alyson, can you hear me?
Yes, Claire, thank you so much. Can you hear me okay?
Yes, I can hear you.
Yes,
so Alyson,
wonderful.
The floor is yours, and I will be back for the Q&A after.
Okay, thank you. I really want to just express my thanks to Claire, who reached out to me originally to tell me about this conference, and I'm so impressed that such a day like this was student run. I think that's wonderful to be able to empower students to sort of put together something that can uncover bias. So much bias in our world is unconscious or invisible. And without uncovering it, we really don't have a chance to fix it and to create sustainable change. So I've learned a lot over the past couple hours. I've been able to catch some of it because I'm coming to you from the US, so it's a little bit of a time change. I think what I can bring to this conversation is to showcase how something as complex as the medical field and how health actually has lots of systemic bias that's thread throughout it. And then, hopefully I can inspire many of you here to use your skill set to help fix this for the sake of women and men. So I am an emergency medicine physician. So that means I see pretty much everything that can occur. If it can occur out there in the world, I see it in my emergency department. So it really was my definition of becoming a doctor. I was very excited in this field. I wanted to fix things and to save lives. And what I found was that I could see the entire breadth of the spectrum of health and disease. And as I started really gaining my experience, I began to notice that there are biases that are at play here. And more importantly, biases and lack and gaps of knowledge on women's health. And so I started to begin to explore, why is it that when I see a woman, she's more likely to die of a heart attack than men, that she's more likely to have negative side effects from medications than men, and less likely to be diagnosed accurately. So I really, at that point in time, looked back to see, well, what's happening here? And many of you can probably relate to this in your biology or science classes, or if you're involved in medicine and health, where we were taught a very simplistic view of what makes up men and women. We were taught that an egg and a sperm come together and they decide whether your sex chromosomes are XX for female or XY for male. And then those chromosomes decided if you would get ovaries or testes, and then they would regulate estrogen or testosterone, growth, that sort of thing. And then that was it. That was the package, right? Everything else, we were pretty similar enough that was kind of what it was thought. And then as I started looking at the literature and looking at my patients, I thought, the truth is, I'm there on the front lines. Like, what do I see? Why is it that 78% of all autoimmune diseases occur in women and not men? Why is it that men are 30 times more likely to die of sudden cardiac death during exercise than women? Why is it that over 80% of the hip fractures that occur in the US every single year are in women? Women have things like irritable bowel and migraines and things that are well understood. So I thought, even when a disease occurs in both men or women, someone seems to have a greater incidence or a greater severity than the other. Why is this something that we have not embraced, right? Why is it that we missed something here? This was not taught to me, and it's not part of our scientific understanding. So it really dates back to how human subject research first came to light. And I know this is a glim slide, right? But it was actually. When we first started to experiment and think of things in a scientific way, we experimented and studied imprisoned individuals. So if you think about World War II and concentration camps and enslaved individuals, throughout the world and in the United States. So what happened was, in 1973, the U.S. created the National Research Act, which said that we need to have informed consent, right? Humans have rights in this, and we need to have a governing body that reviews whether research is fair and whether humans have an opportunity to have informed consent and decide whether they want to join that study or not. That was critical. I mean, that is, we established the review boards, we established all of these laws. But what got tagged along with that was the fact that women of reproductive age would be considered also a protected subject. And that's because of a couple experiences where women would receive a study drug and then they would have malformations or teratogenic effects, we say. There was some sort of effect on the baby. And that was very scary. And so there definitely needed to be some sort of process there. But what happened was all women were considered protected subjects. And researchers at that time thought, that was probably beneficial because we really wanted to simplify our understanding. We wanted to make sure that 2 + 2 = 4, right? Get out all the confounders. So when we just studied men, and that's what happened, we studied male cells, male animals, male humans, it removed the fluctuating menstrual cycle as part of the confounding potential factors. So it became simplest. And what happened is that, women were considered, that whatever we would discover in men would work enough, in women. And in order to increase the power of the study, so if you bring women into a study, you might have to have more numbers of women. It might be expensive. You might have to look at how the menstrual cycle takes place. So basically, when we really started ramping up our understanding of cardiovascular disease, our major cardiovascular trials, our stroke trials, really understanding the mechanisms of cancer, they were all done in men. And then applied to women. And so what happened was, if we are studying all of these conditions with high public health significance in men, the one thing we couldn't study in men was the obstetrics and gynecology and breast health. And so then we went and studied those things in women, and it really just tracked all the efforts into providing medical care for women into only those issues. So if you even look at my textbooks in medical school, it is the anatomy and physiology were all male-dominated, male-centric. And then there would be an insert of, here's female anatomy, here's the physiology of having a baby. But the rest of our understanding of health and disease was through studying men. What is an example of how that has trickled and affected health for women is very well laid out with the drug Ambien, so zolpidem. Many of you might be familiar with what happened here, but Ambien is one of the most widely prescribed drugs to treat insomnia. And it's most likely prescribed to women because women are diagnosed with sleep disorders more often than men. So this drug was on the market for 20+ years. when the original studies really were done in men and did not highlight any sex differences at all. So the dose of this drug was 10 milligrams, and it was based on male physiology and studying males. But what happened is that there were some post-market surveillance reports. So after a drug is put out in the market, anyone, patients, pharmacists, physicians, can go on and put in an alert saying that over 1,000 alerts were placed that in the morning after taking Ambien, women had impaired driving and were involved in motor vehicle crashes. And so that prompted a little bit of scrutiny. And so the drug company wanted to make a new formulation of the drug, and they decided, let's look at this in both men and women. And so they gave the drug to both men and women, and they weighted the amount of process, like make sure you get 4 hours of sleep if you take this medication. And they did that. They waited the 4 hours, and they put men and women in driving simulation studies. So these are the same studies that we use to determine the effects of blood alcohol in driving. What happened is the women crashed the cars. The women did horrible. So they checked the serum concentration of Ambien. And when they checked the serum concentration, women had 2 times the serum concentration compared to men. They were given the same exact dose, but women metabolized it at a slower rate. And so that's what prompted the the Food and Drug Administration, the US, to have its first sex-specific dosing recommendation. So now it's recommended that they have 5 milligram dosing and men can have 10 milligram dosing. This is evidence-based approach of capturing data, right, for risk modification, and for safety. As an emergency medicine physician, no one is going to put in a report because of a neck strain. These are life and death situations that occurred with this one drug that was on the market for 20 plus years and resulted into life and death situations in women. I mean, how many other drugs are out there, and why aren't we taking this into consideration? Because now when we're discovering that there is a difference, say, in metabolism of that particular drug between men and women, science is now looking at why. What is the cause of that sex difference? Is it the biological sex? Is it the fact that your sex chromosomes are either XX or XY? Because those chromosomes are not just in the ovaries and the testes, they're in every cell in the body, right? They're in your stomach. Women have slower gastric emptying time. They have longer intestinal transit times. They have different gastric pHs. The liver has been shown to have over 1,000 genes that have sexual dimorphism, which means that they express themselves differently whether they are in an XX individual or an XY individual. This relates to renal clearance of drugs. Acetaminophen, which is Tylenol, men will clear it out 22% faster. There are lots of drugs, and not all of them, in fact, almost none of them, have sex-specific dosing recommendations. When you think about how those sex chromosomes affect heart disease and brain issues, I mean, it goes on and on. Or is it because of hormone differences that we have really not embraced? Women have cyclic hormone cycles, of course, every month and throughout the lifetime, pre and postmenopausal. Men have a lifetime variation as well. And if you look at this slide and you see men in the age ranges of 20, 30, and 40, which have really stable testosterone levels, that has been our main clinical subjects. Right? Very, very stable. That doesn't really translate to the real world. When you think about something like a drug that treats seizure disorders, in women, certain drugs can dip below therapeutic levels, which means that they're not helping prevent seizures during certain phases of the menstrual cycle, because our body water and our body mass changes, and estrogen affects all of our cells. So if certain times of the menstrual cycle, women are more likely to have these seizures, what have we done? We've just either told them they can't drive, suffer through it, or you take a higher dose of that medication every day, even when you don't need it, and subjecting them to more side effects and things like that. We live in a gendered environment, right? It's called anthropometrics. And it's who designed my chair? Who designed the relationship to my screen right now? How, women wear pocketbooks and some traditional gender garb and these things. How does that affect who designed those and with whom who it was in mind? For instance, the crash test dummy situation, right? So 4 decades of having safety measures using crash test dummies, we still do not have a female adult crash test dummy used in these studies, right? What is happening there? Well, car manufacturers are designing their car to pass those tests. And those tests are designed to make sure that the male body is safe in that car. So how does that translate to our health? Well, if you are a woman and you're sitting in the front seat, you are 73% more likely to be seriously injured and 17% more likely to be killed. That's either passenger or driver, right? Women have larger pelvic girdles. We sit closer up to the dashboard. Men have stronger neck muscles that can prevent some injuries and some whiplash. These are not designed into our everyday components. Our gendered environment also puts pressure on us. When you walk around and people look at you, people will have an assumption. Are you a woman or a man? And now that gender is becoming less of a binary situation, there's a judgment there, right? And that judgment relates to health. Many, many men are expected to do the more hazardous, conditions and jobs in the workforce. So all the trauma that I see, a lot of it is due to men. Women who wear burqa and cover their skin have less sun exposure. So they are more likely to have lower vitamin D levels, which require sun, and they're less likely to have skin cancer. So you see, all of these sort of expectations in society can relate to our health. And then the observer interaction. This is one of the most interesting and least studied field yet, which is what does the gender of the physician or the researcher, how does that impact health? We do know that if you are a male physician and you have a female patient who's expressing pain, that male physician tends to turn down the volume of that pain when it's a woman and not a man. And it's probably because social culturally, women are allowed to express emotion related to this pain. And so what was interesting is also women, when they have a male physician and they're expressing pain, they will turn up the volume because there's this expectation that the male physician may blow them off a little bit, right? So they really want to make their point heard. So there's this like negotiation that occurs when, there's opposite genders. And I think that that's really quite fascinating. So for many of you, like what we really are looking at now is what is the source of those sex differences? How can we start to really collect the data on what is your hormonal status? Where are you in the menstrual cycle? How can we measure that? What is your genetic makeup? What gender are you involved, that you express yourself, and how does that affect things? All of these things need to be our model for future studies, but then also in data collection, which I think is very important. Because doctors think that we are practicing evidence-based medicine. We go to the literature and we look it up, right? But what is our evidence based upon when 76% of cell-based researchers have no idea what sex of the cell they're studying? They don't know if it's XX or XY or how that relates to their results or generalizability. When animal models are, still primarily male animals. Human studies, yes, we are enrolling more women now than ever before. However, we're realizing that it's not about, bringing a few women into the study. It's about analyzing them separately, right? What you want is enough men and enough women to analyze the results separately to see if there is a clinically significant difference. Because how generalizable is the research that we have been, our foundation to the patient that I see in the emergency department, or to you as patients, or to myself as patients, right? What has that done? What has that framework done to the practice, the clinical practice of medicine, right? So when I was in medical school, I learned this is what a heart attack looks like. It's called the Levine sign, and you feel free to Google it, and you can see the images of a man, typically white, clutching his chest. That's the sign of a heart attack, right? So that's what we were taught. Then I go into work, and I see women that's breaking out in cold sweats. They're complaining of shortness of breath and nausea and dizziness. I don't know what that's supposed to be. I wasn't taught that that could be a sign of a heart attack in women. Right? So then there's a delay in that woman seeking care because they're not recognizing it. There's a delay in, when they finally do show up to the doctor's office, there's a delay in the triage nurse from getting an EKG, or delay, maybe the doctor doesn't even recognize this. Our tests that we use to determine whether you're having a heart attack are designed to look for male patterns of heart attacks. So there's this huge gap in understanding of knowledge of women on these conditions that we think that we've pretty much worked out. I thought it would be interesting to just briefly show you, demonstrate with a patient, some of the issues that are at play. So there's a female patient, and she is having some chest discomfort. She's feeling a little nauseous, a little short of breath. So she stops what she's doing. She's a busy entrepreneur in her office, and she says, I've got all these deadlines and everything, but I'm going to go to the emergency department. And so she's anxious because she just left her work, and now she's here, and it's an environment she's not comfortable with. So she's, the doctor sees her, and the doctor says, you look anxious. Why don't I give you some Valium, or, Ativan, or a little relaxer, right? Benzodiazepine. And she's like, okay, I guess I'm anxious too, but, and then so the doc checks back after, gives her that. And she doesn't feel anxious anymore, but the chest discomfort is still there, right? So then the doctor says, well, it's listed here on your chart that you have a reflux. That you have GERD, you have acid reflux. So let me give you this Maalox and lidocaine concoction. It's really helpful for GERD. So gives that to her, and now she feels that it didn't really do much. So the doc checks back and says, it must be musculoskeletal because when I press, it hurts. So let me give you some ibuprofen for an anti-inflammatory. So she takes that, and doc checks back and says, how are you? And the female woman says, it's getting worse, actually. It's getting more painful. So the doctor says, here's some morphine. Let's just treat you as having pain, and then I'll figure out and I'll order some blood tests. Not realizing that women are more likely to have nausea and vomiting when given morphine. They're more likely to have respiratory depression. So now the doctor has to give her a medication for nausea because she starts vomiting. And so now some of the blood work starts to come back, and the doctor realizes that she could be having a heart attack. Let me now give her the nitroglycerin under her tongue, right, to treat this. This is not far from the truth. We have never studied all of these drugs together, never mind in women's bodies. And what's happening is women are hearing this. They're hearing that that this could be all in their head. It could be their anxiety. Maybe it's their fault. Maybe they could be pregnant. Go see this specialist, go see that specialist. And then they're giving all of these medications that are making them feel even worse. And then they need other medications for that. We have no, real handle on drug-to-drug interactions, especially in women's bodies. I thought this was really interesting too, because this was from the Netherlands. Treat me like a lady, right? Healthcare is based on the male body. And so what do we have to do to make sure that we are embracing the difference between women and men in our health and disease? One of the things I think is also really important for this audience is, as you are designing these technology programs that are going to help us fill these gaps, please be very cognizant of language, right? So to demonstrate this, many of us, are taught that, well, in men, there's typical presentations of disease. So we call how men present with disease typical, and then we call how women present with disease as atypical from that, right? So that's not okay anymore. That's not accurate. What we are experiencing is that men have typical presentations of disease for males, and women have typical presentation of disease for females. And we should be reserving the word atypical for any variation from that. We have two different physiological, anatomical, hormonal, genetic, environmental human beings here. We have looked for so long at women as a subgroup of men. And that's something that we need to change the way that we think. While we are changing the way that we think, we better really get up to speed on non-binary issues. And when there's a divergence of the sex versus gender. So when we say sex, we mean what is your biological chromosome complement, right? Are you XX or XY? And gender is what do you consider yourself in society? And what we need to do is make sure that we are collecting that data as well, so that I can go to the literature and say, okay, what is your biological sex? This is what that's telling me about that. What is your gender identity right now? This is what science is telling me about that. And I can individualize my care for this person. And so there's been suggestions that when we are enrolling subjects and when we are collecting data, that we have categories for what is your biological sex, as far as you know, what is your current gender identity. And I also think we need to say, are you taking hormones? Are you on hormonal replacement therapy? Are you on oral contraceptive pills? Are you taking hormones to transition into another gender? Because we're looking to see how that affects your health as well. And then just briefly, what is the life cycle of scientific literature? Because this is where you see that there's many places where we could actually fix. So if someone wants to have an idea, they look at the literature, right? What already exists? And we know what already exists is that it's very male-centric, right? So if we have a new thought, it's kind of hard to just all of a sudden make your proposal to be a study that is going to be done on women or include women, because there's really no precedent for that yet. So that is a challenge and one that we need to overcome. So once you create that proposal, you then need to obtain funding. Well, what about that funding agency? Shouldn't they make sure that you are including women and that it's designed to study the sex differences if there? What about those review boards? There's another opportunity for that committee, anyone on that committee, to just bring it up and say, where are the women? Where is your analysis based on sex and gender? Then you want to get it published. There's a journal editor that has to, that's the gatekeeper. Why isn't that gatekeeper pointing this out as well? In order for it to get published, it has to go through peer review. Many people in the scientific world act as peer reviewers, where, we should be really bringing this up, because then this is the literature that's going to get disseminated, and then the cycle moves on and on. There are guidelines that the International Committee of Medical Journal Editors have put together that allow checklists to look at this, right? Checklists for the author that's writing it, checklists for the editors and the peer reviewers. These guidelines need to be embraced and enforced. Guidelines are guidelines. There are no rules associated with that, but this type of focus. However, that's an option. Our National Institutes of Health, which is our major funding body, has really put together modules and toolkits and all of this learning so that we can teach what are the components. How do you start to study sex as a biological variable? This work came out of the Office of Research on Women's Health, which is run by Dr. Janine Clayton. And it just goes to show you that one office that is designed to consider women what they have done is they've disseminated this concept through all of the institutes and centers of that funding agency. So it's not just if you want to do research on women, you go to the Office of Research on Women, Office of Research on Women's Health. It's if you are doing stroke. They've really sort of disseminated this throughout the entire funding agency, and that shows you how important a female lead researcher and funding director can be. The Canadian Institute for Health Research, also their sex and gender section is run by Dr. Kara Tannenbaum. And that office, and she has put together wonderful modules that are very fun to do on how to include both sex as a biological variable and gender. So really, like, having these training opportunities and just being a female that has a opportunity to make sure that bias is uncovered and to allow mechanisms for improvement, I think this showcases it. And now their strategic plan is that this is just good science, right? This is just good science. Science is about evolving. Scientists want to really to discover new frontiers. I don't think it was purposely done to really ignore women, or it just wasn't realized how different we really are. So there's that awareness and that desire to evolve. Many journals now, at least in the scientific world, are really adopting guidelines in order for you to get that published. And I thought this was fantastic too. The British Medical Journal, which they just decided, okay, we're going to do resolutions for all aspects of scientific literature. And so they made sure that their editorial board is 50% male and 50% female. They try to make sure that they look at who do they ask to be the peer reviewer, make sure that there are women there too. Who are they asking to do editorials? And who are the main scientists that are actually getting published? The first, second, and last author are usually the more senior and the ones who have done the most work in that particular project, and making sure that there's enough representation of women, making sure that as they are recruiting people for the employment, that's considered. There's always awards. Who's on the awards panel? Who are the judges that are creating this? Make sure that there are equal representations, and no males, right? This conference certainly has had great representation of women, and so making sure that you're just not having 6 men in a panel discussion. Make sure that these processes are part of the annual review. Don't stop reviewing them. And this type of influence can really change scholarly publishing. And if you change scholarly publishing, you're going to change health and our understanding of disease and science. So really, in conclusion, I implore you to control the narrative. Right? So there's this study that came out about smartphones, and it looked at Android, Siri, some Apple, Google, and Microsoft smartphones. And they asked the smartphones a series of questions. One set of questions was very physical health. I think I'm having a heart attack. What should I do? And they performed pretty well. And they said, you should go to the emergency department. Here's, call 911. Here's the number for your local physician. But when they asked them things of mental health or of women's viewpoint, as in, I was raped, I'm depressed and thinking of suicide, I was beaten by my husband. These are the questions that they asked. There was so much inconsistency and no knowledge based into the platform that many of them said, I do not know what you are saying. That was the sort of answer of the smartphone. So what we need is who's actually putting those tools in? Who's creating the tools that are going to look at risk factors for heart disease? Many smartphones now or apps are trying to look at, what is my risk of having heart disease? I want to make sure that that includes, what is your biological sex? What is your family history? Did you have any complications around pregnancy and delivery? Because those are sex-specific risk factors for heart disease. What are the data for drug-to-drug interactions if you are, if your metabolism is based on female sex? These are the types of things that if you are part of any sort of committees, scientific committees, marketing, and informatics, making sure that the bias gets erased because of the diversity of those people who are creating these tools. You can reach me on Facebook or Twitter, Instagram. Thank you for letting me showcase my book. My book really goes through emergency department patients, that really where I can highlight where certain biases are at play, and then what we can do as patients to really to decrease those biases, to gain control over your healthcare system. How do you manipulate the system right now, even though it is very male biased? And so I give tools for that for the general population, and so I think that would be, in general, very helpful. But I wanted to sort of give you, as the entrepreneurs that are going to create our new future, please be aware at how complex this system is, and you can see where bias is thread throughout. So I'm very happy to take questions, and please feel free to hit me up.
Thank you, Alyson, for that strong testimony. I think, yes, it's so crucial to explain to the women in the YouTube Live and even more in the world that bias in medicine may have dangerous effects on our health. So now we will have some Q&A, and I think we are all a little bit curious about your own career. I mean, have you ever faced some difficulties as a woman in the medical field, especially when you have decided to choose the women's health specialization?
Yes, absolutely. So I am the first physician in my family. So I really just felt as though, I heard another speaker say this, I was brought up with the feeling, the belief that I could do whatever I wanted if I worked hard enough. And so that simple, foundation made me feel as though, great, I want to be a doctor. And so I found that it was very difficult along the way. I went through at a time where there were not 50% of medical school enrollments that were men and women. Not only that, when you look at leadership in medicine, so even though we have 50% applicants, that 50% medical students enrollee, when you look at the leadership structure, it really drops off for women. So those who get promoted to professor, those who are running chairs and having these leadership roles. So there's still an issue there. But I sort of felt as though I embraced my feminism. I was very grateful for the women's movement that created, at least a revolution of realizing that equality needs to be worked for. And then, of course, when I decided to study women's health, that's where it really sort of hit me that from the patient point of view, women's health was reduced to simply the reproductive system. And so when I said that there's all of these differences, I got a lot of backlash. This is like 10, 15 years ago. People didn't understand what that meant. As evidence started to really come to light, it's hard to argue with data. And so what I decided to do was then start creating the data. So then I really created my research division, and we have really sort of added to the understanding of how sex differences impact emergency care. And so then you really don't have an argument, because I'm showing you that these differences can be clinically significant. Also, the last piece is with COVID, with COVID, the sex data is leading towards men having higher mortality rates. And so what that's done is really showcase that sex and gender differences are not about solely women's health. It's about good science. And so I think making sure that men join the table for the discussion has been really helpful.
Yes, I totally agree. Maybe we have a specific question on a scandal. Did the thalidomide scandal and its effects on pregnant women raise awareness on gender differences regarding drugs prescriptions?
Yes, that was really the key moment, was thalidomide. That's what sort of created that fear of removing females of reproductive age from. That's what the law was intended to do. But I think what happened was it just became all women. So instead of excluding women of reproductive age, which I think is wrong. They also just excluded women in general, so of the entire lifespan. We don't really want to exclude women of childbearing age. We want to understand what the risks of doing that research. What are the risks of taking that medication in a woman if she gets pregnant? Think about pregnant women. We don't really have much of an understanding at all of the health of women during their pregnancy, right? We don't want to study the medications. Many of them have to stop taking their antidepressants and their important medications. What we need to do is go back to those cellular studies, go back to the animal research studies and the preclinical studies to look at the safety of these medications in reproductive age animals and reproductive, what if they got pregnant? So I just think it's time for us to get complicated. Instead of removing pregnant women, instead of removing women of childbearing age, those are the women that are really out there needing care. So thalidomide definitely showcased an important consideration. Nobody wants to have their fetus have adverse events or teratogenic effects. However, we went overboard, and now we need to just go back and really look at our scientific methods have advanced considerably. So we should be able to start to look at these things from the whole spectrum on.
We only have time for one last question, and it's more about entrepreneurship. As women's needs are less taken into account, how does that make a huge opportunity in the FemTech sectors?
Yeah, I think that this field is wide open for so many aspects. So when my division, and I have fellows, and I do a lot of teaching and mentoring, I say that this field is wide open. Basically, I look at it like an iceberg, right? So once you start to look, you find it's like, oh my gosh, I didn't realize that sex difference occurred. I didn't realize that women were not included here and in this concept. And I think that especially with FemTech, there's amazing opportunity for you to write the code, for you to create the apps and the technology that can import some of these complicated factors of the menstrual cycle or our own physiological differences. So I think that there's going to be more and more of a need, and you want to be ready to fulfill it. This is not going away. So science, like I said, evolves. And once we realize that these differences exist, once you check the serum concentration of a drug in men and women, and then you realize there's a huge difference, you can't unknow that, right? And so now people are looking at what action am I going to take to prevent that? And I think that's where this audience can really come in and be ready to create the code, create the scientific tools, make sure that the tests that we use to diagnose these conditions in hospitals and at home and are all taking this difference into effect. So I think that if this is something that you want to focus on, even if it's not, whatever it is that you want to do, stop and look at whether or not this, whatever it is you're creating, would benefit from looking at men and women in a different way and embracing those differences, I think is really where the future is headed.
Thank you very much, Alyson. Unfortunately, we do not have enough time for the other question. So I hope all the people on the YouTube will have learned a lot of things and have a good day in the hospital. Thank you, Alyson.
Thank you. Thanks for having me.
Bye. Now I will let Mariana say a few words in order to close our booster event. Thank you, everyone.
Hello, everyone. I hope you all had a fantastic day. We started the day with this great overview about the topic about women in entrepreneurship. Then we had this fantastic debate. In the afternoon, we had amazing women from many different industries showing us that the sky is really the limit. And then we had this amazing conference. And I think probably you already have even more questions. And so it's definitely a huge debate that we have ahead. So don't hesitate to continue talking on the social media, on LinkedIn, on YouTube, in the comments. Don't hesitate to share the event. And I hope you all had a fantastic day. Last but not least, I would like to thank HEC Paris and École Polytechnique, most specifically Ambroise Collin, for supporting so much this project. Alain Bloch and Bruno Martineau, Lily Tucteau and Marion Merel, thank you so much for all the help in this past months. We would like to thank so much the BIVOC team from BNP Paribas for hosting us and for helping to make this event possible in such a short period of time. Thank you so much. It was really an amazing mission. I would like to thank Jean-Philippe Tournier, Charles de Bodina, Florence Bitou, Annelise Lajuy, Karishma Vadera, Emmanuel Larcher. We would like to thank all the speakers today. It was fantastic. And then I would like to thank the amazing Boost Her team, all the girls that helped us to make this day come true. So Margot Boulet-Morel, Elisa Muller, Julia Sarfati, Vincienne Lucier, Esther Pertuissel, Clémence Berguier, Emeline Fasolato, Luana Davy, Hayon Park, Anastasia Mikhailov, Clara Cornu, Claire Trécart, Julia Sisto. We made it, girls. And last but not least, I would like to finish the day with a quote from a very special person, a very special woman for me, that is my mother. She always tells me, I give you wings to fly, but know that you always have a welcoming home to come back. Based on it, it's our responsibility to give wings to every woman out there to fly and make society a safe and welcoming home for every woman. Thank you.